So we are recording this event today for the Junior Investigators Network and the Delaware CTR Excel program. So your questions will be repeated from the speaker up front, and this event will be available online through Patientcenteredness. It is my great pleasure today to introduce our speaker for today's workshop, Kimberly Bailey, who's sitting right here, came up from Washington. She is a program officer in clinical effectiveness and decision science for PCORI. She previously served as a program officer in the research synthesis program with the Office of the Chief Science Officer, where she led PCORI's efforts to scope an array of potential topics for new research, assisted with the development of targeted funding initiatives, and managed a portfolio of evidence synthesis projects. She joined PCORI in 2014 as an engagement officer and acting as liaison between the science and engagement departments to ensure meaningful engagement of patients and other stakeholders throughout the course of PCORI-funded projects. Subsequently, she has served as a program officer in PCORI's Clinical Effectiveness Research Program, where she is now. Prior to PCORI, Kim was a research director and program director for health system improvement at Families USA, where she led the organization's work on payment reform, delivery reform, and quality improvement, and provided quantitative policy analysis on a range of healthcare issues. Her BA is in Planning, Public Policy, and Management from the University of Oregon, and she has a Master's of Science in Health Policy Planning and Finance from London School of Economics and the London School of Hygiene and Tropical Medicine. So for people that have questions or interest in PCORI, Kim is the one that you should be talking to. And she's going to do a presentation, but we'd like to have that presentation be fairly open. So if you have questions along the way, ask Kim, just raise your hand and we'll recognize you. And hopefully we'll have some robust discussion at the end. But please join me in welcoming Kim Bailey.
Thank you so much for that warm welcome, and it is a pleasure to be here today with all of you. If I could just get a show of hands from those of you who have heard of PCORI before. Okay, good. So you're all, or most of you, about 80% I'd say, are relatively, or at least know the name PCORI, the Patient-Centered Outcomes Research Institute. My goal today is to tell you a little bit more about our institution and to walk through the funding opportunities that we have available to you. So I really want to focus on also how you can be successful at getting funding from the Patient-Centered Outcomes Research Institute. And hopefully you can share this with your colleagues as well. So I'm going to start today by talking about what PCORI is, who we are, and what we do. For those of you who don't know, PCORI was authorized by an act of Congress in 2010. It makes us a little bit of a unique organization. We're actually an independent nonprofit that was authorized by an act of Congress. There aren't many of those that exist. We are a 501c1 organization. It's a unique designation under the tax code. So we're not actually a government entity. We're a private nonprofit. But we are responsive to the Government Accountability Office, and we receive a review by Congress as well for our work. And our mandate, the authorizing legislation that founded PCORI, requires that we fund solely clinical comparative effectiveness research. So option A versus option B. And I'll talk a little bit more about that as we go, actually quite a lot more. And I'm happy to answer any questions that you may have about what comparative clinical effectiveness research is. The other thing that was part of our mandate, as we'll talk a great deal about today, is that PCORI be responsive to the questions that matter to patients and to other stakeholders within the healthcare landscape. So that's an overview. Early on in PCORI's life cycle, we created a mission that was responsive to our authorizing legislation and 3 strategic goals. And the first strategic goal is, of course, research focused, that we be generating research that is responsive to those questions that stakeholders have. But we have 2 additional goals that I want to highlight. The second being that we get data, information, findings into the hands of end users, so clinicians, patients, and families, more quickly. We know that research often gets done and it sort of sits on a shelf. One of PCORI's strategic goals is that we move findings into practice more quickly, and we sort of find ways to creatively implement and disseminate findings more quickly. Our third strategic goal is that we start to try to influence other research funders and institutions at making research more patient-centered and engaging clinicians, patients, and others in the research process. And as Ron said, please do ask questions as we go, especially when we get to the parts about PCORI's funding opportunities. We have quite some time today, so if you have any questions, do feel free to stop me. So I want to focus a little bit about what CER and PCORI is and why it's important to have an institution that funds solely this work. We've got NIH, we have AHRQ. What is the role that PCORI fills in the research landscape? For all of the good work that's done in research, there still are a number of questions that aren't answered. And there really are a number of questions that when you get to an individual patient level, a patient making decisions in partnership with a clinician, where there aren't data available to help guide those choices. And that is what our authorizing legislation says we really need to focus on, improving the availability of information at the point of care upon which patients and clinicians can make those choices. So that's really what this fundamentally is all about. A few things to highlight where we're different and what the work or what makes the work that PCORI does a little bit different than other funders, as I've already highlighted. We're, of course, looking at what works for whom, so that heterogeneity of treatment effects approach, getting at what works for individual patients and sort of precision medicine kinds of things to improve the availability of information upon what works in subgroups is of great interest to PCORI. We're also, as I've already mentioned, interested in answering the questions that matter to patients and clinicians and to doing things in a real-world setting. But I also want to highlight two other things that makes our work a bit unique, and we'll come upon these things many times in this talk. The first is the how we do that, and that's the engagement process. The questions that PCORI funds upon, the research that we are funding is guided by the interest of patients, clinicians, and stakeholders in the healthcare arena. We require that there be engagement in determining what we fund. And so as a researcher applying to PCORI, we expect that you will have talked with the relevant groups in a clinical area to help to define your research questions and the outcomes that matter. And we'll talk about how that gets put into play in a research study in a lot more detail, but I do want to highlight that piece of engagement that does make PCORI work unique. And then the last thing is the why. Why do we do that? Why are we encouraging this engagement? And the why is that our belief as an organization and our authorizing legislation makes us do this is that we believe that if you get the questions right, if you get the outcomes right, you'll have research that is more relevant, meaningful, and trustworthy, and it will get implemented into practice more quickly. So that's really the goal here, is to make research that has meaningful findings and that will get translated into practice quickly. The engagement piece, because I know it's a bit unique, people say, well, what does PCORI as an institution do? How do you engage these various groups? I wanted to talk a little bit about what that looks like in the work that we do as an institution, and then we can also talk a great deal, if it's helpful to you, about how that work can happen at the project level as you're developing a research proposal to PCORI. But it's sort of the high level of what PCORI is doing. We engage stakeholders in all of our work. When we're talking about the topics that we're going to fund, our calls are for priority topics and questions. We have priority lists built into some of our funding announcements. We're engaging every stakeholder group in the healthcare arena in those discussions so that we're trying to glean data on what's going to be meaningful and relevant from all of those groups. We also include patients and stakeholders in our peer review process or a review of applications, and we'll go over that in a little bit to show you what that looks like in practice and what you can expect as a potential applicant to PCORI. Your application will be reviewed against in these areas. And we also involve patients and other stakeholders and the dissemination and implementation of results, again, in an effort to truncate the amount of time that it takes to get findings into practice, and in the evaluation of our work so that we can continue to be a learning organization and improve our efforts. So just as something that you have as a reference point, when I'm talking about stakeholders, I'm talking about everyone who touches the healthcare system. Patients and clinicians being critically important because they're the ones who are making healthcare choices most frequently, but also family members and caregivers who are helping patients make those choices, health systems and hospitals, training institutions, payers and purchasers, so employers who are buying health coverage for their employees, and insurance plans who insure lives in this country, and industry, so the pharmaceutical industry, the device industry, et cetera. Those are all of PCORI's stakeholders, and we do engage all of them in the work that we do. So before I go on to talking about the research that PCORI funds, does anyone have questions about that overview of how we started and some of the things that make us unique? That's a great question. So the question was, what's the relationship between the government and PCORI? Our authorizing legislation requires that we work in partnership with other research funders, namely in the legislation, the NIH and the Agency for Healthcare Research and Quality. So a lot of what PCORI does works in partnership with those organizations to ensure that we're not duplicating efforts. And so, for example, in our targeted funding work, we often partner with the relevant NIH organization to make sure that we're not duplicating funding efforts where certain priorities may have shifted within NIH. We can fill that gap. And so we're trying to make sure that we're synchronizing efforts there. With AHRQ often does the dissemination and implementation of healthcare findings, and so we actually work very closely with them to promote products that they do, to do some products in partnership with them, and to ensure that, again, that we're not duplicating efforts.
So, focus, there's a whole going out better but it sounds like PCORI is only looking for that end product. We have intervention A and we have intervention B. So there's not support for those earlier phases.
That is a great question. So it's a long question to paraphrase, but basically the gist of the question was, is PCORI funding the early stage of doing the engagement to get to the end developed interventions, the comparison of intervention A versus intervention B? And the answer is, when you get to the point that you're applying to PCORI for a research award, we do expect that you have done that pre-work and that there is evidence of efficacy for the proposed interventions. And we can talk a great deal about that as we go today. But the second half of the response is that we do, in fact, have a funding mechanism that I'll go over toward the end of my talk. The last piece will be other funding opportunities that we have available. We call it our Engagement Awards Program. And that program is intended to bring clinicians, researchers, patients, other stakeholders within the healthcare system together to talk about priorities, research priorities, to develop core outcome sets, to talk about the research questions of interest. So to do that sort of prep to research. Those awards are not research awards. They're intended to get a community ready to do patient-centered outcomes research.
If policymakers are, is there effort also to look at things outside of treatment, like
so the question was, if policymakers are one of the stakeholder groups of interest, is there a desire to look at interventions beyond clinical interventions to those that are looking at the determinants of health? And the answer to that is yes, there is. Now, I will caveat that by saying we do fund comparative clinical effectiveness research, and the advocacy component is key. But as we'll talk about as we go, the funding announcements that we have available, we have a program at PCORI that is focused on health delivery and disparities research. And that program, particularly, I'll highlight a funding announcement that we have around addressing disparities, which does in fact call for applications that are getting at improving outcomes around determinants of health. So that's not quite a direct answer, and I'm happy to talk more offline to get the specifics of what you're seeking. Anything else, or are we? Okay. So now I'm going to talk a little bit more about what comparative effectiveness research is as PCORI sees it. And this is all sort of putting things in the lens of how you can be successful in applying to PCORI. I'll also talk a little bit about what we don't fund, and talk a little bit about how you can be successful in applying to PCORI. So in a very high-level nutshell, comparative clinical effectiveness research is direct comparisons of the benefits and risks of two or more approaches to healthcare. So that can be very traditional clinical effectiveness research, a surgical option versus a non-surgical option, drug A versus drug B. Or it can be models of care. We do, as I mentioned, have that health delivery and disparities research program that is almost solely comparisons of models of care and looking at the clinical outcomes that occur as a result of implementing two models of care. It's very important when you're applying to PCORI that you explain to us how your research is comparative, and that you very clearly define what those comparators you are proposing are, and you state why the comparison is important to decision makers. I know that sounds sort of silly, but the easier you can make it to both PCORI staff who are reviewing your letters of intent as a first line, and we'll get through what that review process looks like in a little bit, and to the peer review panels that are ultimately going to be reviewing your full application, the higher the likelihood is of success. When we talk about evidence gaps that are important to patients and stakeholders, this is critically important. So part of our authorizing legislation is that PCORI is responsive to the questions that matter to patients and stakeholders. And how do you, as an applicant, demonstrate that to us? You show us. You show us with data from systematic reviews saying that there's a clear gap, that clinicians don't know whether option A or option B is better. You show us with pilot data. You show us with pilot data that shows that there is evidence for both of the interventions that you're proposing. And you also show us with variation in care. You know, if there's significant variation in care that's occurring, and you can document that, demonstrating that the gap is there and that your study will fill it is how you're successful. And this all gets back to that. If the gap isn't important, the research that is funded won't necessarily be all that useful. So your job as an applicant is to tell us why your project is critically important and how it will fill a gap and get implemented quickly. I'm going to talk a little bit about what our authorizing legislation called out as priorities to us. Because as you'll see, it's pretty broad. I mean, it's basically anything that you could find within the healthcare system, but I think it will get to some of the questions of sort of how you frame an application. So our authorizing legislation called out that we're supposed to be focusing on high priority conditions that pose a significant burden on the US population. So if you're looking at diabetes, there's significant morbidity and mortality due to diabetes. It's a very high impact condition. And sort of contrasting to that, our authorizing legislation calls out that we should also be looking at rare diseases. So conditions that put a disproportionate burden on a small population. So there is an interest specifically on rare diseases if that's something that you're interested in. We also have 11 populations that are called out as being of priority to PCORI, and it really does cover, these 11 cover the whole gamut. So women, children, low-income individuals, the LGBT community, people with disabilities, veterans, etc. It's helpful in your application if you can highlight which of those priority populations your study will be targeting. And we fund research that is patient-centered, and I think it's important to note what we mean by patient-centered because it's something that's a bit of a unique and new term. And we also talk a great deal about patient-centeredness and engagement, and things get muddled, so I think it's really important that I highlight the difference between the two. How we at PCORI define patient-centeredness is that a study is aiming to answer the questions that matter and to look at the outcomes that matter. So often what we see with investigator-initiated research is that there might be a question that's of great interest to the investigator, but the outcomes aren't necessarily something that are of interest or utility to patients and clinicians. And so it's very important that you ensure that you can demonstrate and tell us in your application why what you're proposing meets that patient-centeredness criterion. And then as far as engagement goes, what does that mean? It means that you've talked with the people who will be using the information that's generated by your study to make sure that you're getting that question right, that you got the outcomes right, and that you've talked to them too about how to get the information that's generated into the hands of those who are going to make decisions. So not just thinking about a dissemination strategy that involves publication in a peer-reviewed journal, which is very important, but looking at creative ways to disseminate it. I'm just going to highlight a couple things that we don't fund. The first that's probably most important, because this is part of our authorizing legislation, that we specifically cannot fund cost effectiveness analyses. So that means that you cannot directly compare aggregate cost of intervention A versus intervention B to the system. But the important caveat to that is that on the next slide, it is entirely fine for you to look at costs to the patient. So out-of-pocket costs associated with services, healthcare utilization, entirely fine. Basically, you can do anything that's patient-facing, but not actually take that next step to doing a formal cost-effective. And I'm happy to talk with you offline if you'd like to know more about what sort of falls in and out of that. The other thing that our authorizing legislation say that we cannot do are studies that are specifically intended to develop guidelines or to change payment policies. So public insurance plans and Medicare, Medicaid are stakeholders of ours, as are policymakers. The information that is generated can certainly be used to downstream inform policy decisions, but you cannot specifically be intending as an aim of your study to change guidelines. I want to highlight where we funded thus far and how much we funded, because we're relatively new. So we started issuing awards in 2012, and we now have more than $2 billion awarded across 41 states in the District of Columbia, including Delaware. So our spread is getting larger, and more than 600 research awards. So we've got a lot out the door quickly. Not surprisingly, the vast majority of what we funded falls into areas that are topic areas that you're all familiar with. So mental and behavioral health as a topic has been the most common. Cancer, neurological disorders, and cardiovascular diseases right up there. I'll also highlight the light blue on the circle graph on the left. We funded a great deal in methodology. So if you're a methodologist, we'll talk about this in a little bit, we fund in CER methods as well. And so we're trying to inform in the future where clinical effectiveness research is going. And we have invested a great deal in infrastructure, so I'm happy to have an offline conversation with anyone interested in distributed data networks using large healthcare system data sets to do research. That's something that we're interested in. I'm not the expert in it. If you are interested in that, I'm happy to connect you with people who are. So before I go on to the funding opportunities that we have available, does anyone have questions about that piece, what we fund or don't fund? It may come up more, but I'm happy to answer questions now. Yes?
Do you fund data mining of, let's say, the Medicare data, all of these other emergent large-scale aggregation of medical records data?
So the question was, do we fund data mining of observational data sets, including claims records, et cetera? I'll respond, we don't fund data mining, but we do fund observational studies. So if you have an observational study that you would like to do that's using robust methods, using EHR data, Medicare data, et cetera, that is most welcome. When you look at the awards that we've issued, I can speak to the Clinical Effectiveness and Decision Sciences program. About half of the studies that we funded within our investigator-initiated effort. So those are smaller studies, as we'll talk about in a few minutes, up to 3 years in duration, typically up to $2 million in direct cost. Those studies, about half of them are observational studies. So they are indeed of interest to us. We'll talk a little bit later about PCORI's methodology standards. PCORI has put out a set of methodology standards that applicants are required to comply with. And if you're interested in doing an observational study, I would encourage you to look at the relevant methodology standards early on, because we do want the study to be as robust as possible.
So the sort of thing I'm thinking that there's a diagnosis, and you see in the billing data that some patients got this intervention, some got that intervention, and then you can look at the downstream outcomes by the billing data. See kind of what I mean?
Yeah.
Comparative effectiveness, but you're using billing data on a large, the whole U.S. elderly population.
So the question was about a specific design where you would look at trends in delivery and then look at billing data to sort of determine the factors driving.
Well, the very outcomes are, because you know from the billing data what the subsequent care looks like with this treatment versus that treatment.
So we can talk more offline. I mean, I think that what it would come down to there is if you've defined what the intervention is in each of those arms well. So I think that wouldn't necessarily be fully out, but you'd have to be cautious about how it was.
Along those lines, so I'm confused about how the comparative effectiveness would fit in with an observation study. So then in that case, are you comparing it to different hypotheses or scientific hypotheses about what you're observing in a relationship?
Not necessarily. It's often so the question, was, would you be comparing two different hypotheses rather than two different interventions in an observational study? Is that?
Yeah, how does an observational study or methodological?
So it depends on what the study is. So for example, there are studies for which it would not be appropriate or easy to do a randomized trial. And so a good example, you have a study that's looking at seizures in a pediatric population. It would be very difficult, and it's early versus prolonged treatment with anti-seizure medication in infants. And that would be a very difficult trial to conduct. So a registry is being used in lieu of conducting a trial. So that is still an example where you're looking at two very well-defined interventions, the early end of seizure drugs versus a prolonged treatment course with anti-seizure medication. That's what most of our studies would be looking at and what would fall into this sort of traditional CDR. But I'm happy to talk more about what might fall into two different models. So, yeah, the question was, could one of the treatments be no treatment? And the answer to that is, if no treatment is a valid treatment choice for a given clinical condition, then yes, it could be. You would just have to make the case that a clinician in partnership with a patient would be having that conversation. Do I do no treatment at all, or do I do a treatment? And so if you can make that case and you can show that not treating is something that's currently in clinical practice, then it would be an appropriate comparator. Yes. So the question was, someone who had applied to PCORI previously, looking at 2 different models of care delivery for autism, and the feedback that was provided was that there was too close a look at fidelity to the interventions, and that was not real world. And so is PCORI looking for real world interventions? The honest answer is there's a continuum there. And of course, fidelity to an intervention, especially a behavioral intervention, is important. So you want to very clearly define and protocolize your intervention. I do think there becomes a point at which you are overly constraining what's happening in the clinical care to where it is not real world and won't be easily generalizable and disseminable. So there's a gray area there. I'd be happy to talk more. I think the sort of takeaway for all of you who are thinking about applying is that the most important thing you can do is very clearly define what your intervention is. And in the case of a behavioral intervention, what the components of that intervention are. The hours of the intervention, how it's structured, who's delivering it, how it's being delivered, demonstrating that it's protocolized, and then demonstrating that there is evidence of efficacy supporting that protocolized intervention, both interventions that you're comparing. We'll talk more offline about perhaps the unique considerations that may have been in play there. Anything else? Okay. So I'm going to talk a little bit about the funding opportunities that we have available at PCORI, and I would encourage you to go to the PCORI website, PCORI.org. At the top, there's a banner that has a funding opportunities tab. Click on that, and you'll get all of the available, open, and upcoming. And upcoming is actually more useful than open, I find. So open tends to maybe things that have already, the LOI date's passed and it's in review. So upcoming is probably your best friend there. These investigator-initiated or broad funding announcements, as we call them, are probably most relevant to all of you. They're awards that are typically up to $2 million and up to 3 years of duration. We have, in response to the field, started to offer more options within this investigator-initiated program to better meet the needs of the field. So now we actually, within the assessment of prevention, treatment, and diagnosis options, part of this funding announcement, for example, we have a large mechanism that's up to $5 million in direct cost and up to 4 years. And then we have our small mechanism, which is $2 million in 3 years. And we've added these additional options in response to feedback from the community that we need more availability of options. And PCORI had, as part of the first few years, we have these 5 national areas of priority, 5 healthcare priorities. And what we did is we started early on in the trajectory of PCORI issuing funding announcements in each of these. All of these now have come together under a broad funding. So you'll see that up at the top, the assessments of prevention, treatment, and diagnosis and treatment options program that I just mentioned. That's sort of your more traditional CER, option A, option B. Improving healthcare systems is focused on systems interventions, as the name implies. And then we actually have a communication and dissemination research award that is comparative effectiveness of different ways to communicate. So it's things like, for example, if you have an already developed decision aid of some sort and you're comparing it to another already developed decision aid for a specific clinical context. It's not for the development of decision aids. We don't fund that within this program now, but it's for comparative studies of different ways to communicate in healthcare setting. And then the addressing disparities mechanism that I mentioned earlier, focusing on reducing disparities in healthcare outcomes. The last is a bit unique, and that's the methodology awards that I mentioned. Those are typically slightly smaller, $750,000. But if you're a methodologist and you're interested in patient-centered outcomes research and CER, that might appeal to you. Does anyone have questions about that, those awards, before I go on to talking about our other mechanisms? And one question we frequently get is, which one should I apply to? You are welcome to reach out to PCORI. There's a slide in here in a little bit that has some contact information. We're happy to talk with you. If you submit a query to sciencequestions@pcori.org, you'll get connected with a program officer, and that program officer can help you to determine which funding announcement might be most appropriate for your question and work. I want to talk just briefly about our Pragmatic Clinical Studies program, because you may have heard of this. We, as I mentioned, started funding in 2012, and then we stakeholders that we needed to be funding larger studies that are more impactful, and in response to that stakeholder feedback, we created this Pragmatic Clinical Studies mechanism. It is really intended to fund large, simple trials. So this is where the previous announcements include many observational studies. This is largely trials. I think of the 31 studies we funded, only one is solely observational. Some have an observational component and a randomized component. And there's quite a bit of variability in the design. So there's, cluster designs for health system studies. But this mechanism is more focused on randomized trials. And if you were to be applying to this, the bar for that engagement and the showing that your findings are going to be producing meaningful change in practice is a touch higher because of the size of the investment. Before I talk about our methodology standards, does anyone have questions about the funding mechanisms? So as I touched on earlier, we have these 12 sets right now of methodology standards. There may be more coming out in a little bit. We have one on complex interventions, which is actually quite interesting because doing CER in real-world settings where you have complex interventions is quite hard. So we've developed a set of methodology standards that talk about how to do that robustly. When you're applying to PCORI, we require that you show that you've adhered to these standards. So these standards are not intended to be a sort of I don't know what the right. They're intended to be a sort of a baseline, a bar, and you can go above and beyond them. They're intended to be minimum standards. They're not intended to be the end-all and be-all. But we do expect that your study will adhere to these standards, to those that are relevant to the design of your study. Okay. Now I'll talk a bit about preparing to apply to PCORI and what you can do to increase your likelihood of success and what the process looks like. We have a 4-step process, which has a 3rd step that's a bit unique to research funders. So the first 3 steps, the competitive LOI phase, the steps 2 and 3 are the peer review process, a preliminary review by a panel of reviewers, and then the in-person review. Those are all pretty standard. The 4th step is unique, so we'll talk about that. Because we have a board of governors that oversees our work, we actually do have another step of review, which is our board of governors panel that consists of stakeholders from every group within our authorizing legislation reviews what we're funding as well. But the first step to get there is submitting your letter of intent. So we'll talk a bit about that. The letter of intent is quite short. It's 2 or 3 pages, depending on which application you're applying to. It's a lot of information to squeeze in there. It's what you've seen before, what your aims are, background significance and approach. The one thing I'll tell you there, because this is CER, the more clearly you can define those interventions, within this very short space, the higher the likelihood of success. And also, the more you can convince us in a brief paragraph that the comparison that you're proposing is meaningful and will change practice, the higher the likelihood of success. So if you have a systematic review or clinical guidelines saying there's a clear gap and more research is needed, put that in there, because that's really going to help you. When our LOIs come in, they first go through an administrative review that don't make it through this administrative review, which is why I'm highlighting this. I would really hate to see a study that's very good not make it through this, simply because guidelines haven't been followed, but it's kind of heartbreaking when you see something really good that just falls outside the number of pages, for example, or doesn't quite make it in before the deadline. We're not the most flexible at allowing things through. So just make sure that you read the parameters of the funding announcement and that you read the guidelines on the format of the letter of intent, for example, before applying. Once it gets through that administrative review, it goes to staff for programmatic review. Each letter of intent is reviewed by at least 2 staff. Some are reviewed by additional staff. So we always have an approach that attempts to take into account the clinical area and attempts to take into account giving each letter of intent a fair chance. If your letter of intent is deemed to be responsive, you'll be invited to reply, and we may provide feedback either way. We've actually gotten to the point where we provide feedback on virtually every letter of intent, whether you're getting accepted or not. And oftentimes, if you're not accepted the first time, we try to provide clear guidance on how you can be successful that second time. So just to highlight again, things that will increase your likelihood of success. If you've got a question that is really meaningful to patients and clinicians, a tough choice that they're making at the bedside, a difficult choice for patients and caregivers to make together, highlight it. That is very important. Having an evidence gap that's clear is also very important. And evidence of efficacy is difficult, especially in cases where you're looking at an intervention that's been newly developed or in a rare condition where there may not be evidence of efficacy. So I just want to highlight that it is needed. The bar for what qualifies as sufficient efficacy depends a little bit on the clinical condition. Diabetes is treated differently than a rare condition, for example. But it's very important that you document your evidence of efficacy. And if you have pilot data of some sort, put it in there. And then clarity and completeness of responses. And this sometimes even gets down to grantsmanship, very simple things such as the way you present things and making it very easy for reviewers to draw out that information. Formatting can make a big difference in success, as can clarity of language. Any questions on this far? That was my last item, letter of intent. Oh, actually, so this is the sort of help slide here. I would encourage you, we do have a number of online resources, both in the form of documents, webinars, some short videos on what we're seeking, both in the letter of intent stage and the full application stage. The request, either you can request by email or there's a little online portal you can click on and submit your request to speak with the PCORI program officer. And then if you have challenges with the website, please reach out to our technical support folks, but please don't reach out at 4:30 on the day LOIs are due. So I would encourage you to actually go into the system and have your letter of intent in there. Know that the system works for you, because it is actually really sad when people wait to the last minute. They've done it in Word offline, can't get it in the system before the 5 o'clock deadline. Great question. We have, the question was when are grants submitted? We have typically 3 cycles. So typically it's the next LOI deadline is June 26th, I believe. the 25th or 20th. It's coming up at the end, toward the end of June. And then the following one will be sometime around October, but 3 times a year. We do targeted funding calls. I didn't add any slides here on targeted funding calls. So occasionally we'll have a very specific set of questions in a clinical domain. We've issued those on various opioid-related issues, multiple sclerosis, extended treatment of venous thromboembolism with anticoagulants. So it's some very much more targeted areas that come off those 3 cycles, but otherwise 3 times a year. Yes. I should know this. It's about a year from LOI due to finding out to notification. 10 months at the short end of that. I mean, it's typically you have about 2 months from the time of being notified to the time a full application is due, then it goes through the merit review process. So around 60 days. Sometimes that's been 48, and sometimes that's been 65, but it's around 2 months. And then it is quite some time between applications being due and notification. Anything else? All right. So I'll go quickly through the peer review process of PCORI, which we call our merit review process, as it is a touch different, not the fact we have one, but the content and the criteria are a bit different. So as I mentioned early on, we engage stakeholders in our peer review process. And what makes our panels that are reviewing applications a bit unique is that they involve and include both patients and other stakeholders. So every application that comes in is assigned 5 reviewers as primary reviewers. There's 3 scientists, one of whom is a methodologist, assigned to each application in addition to a patient and another stakeholder. So that stakeholder could be a clinician with a clinical interest in the topic area. It could be a payer. It could be someone else. It's typically a clinician or a payer. Those are usually the stakeholder reviewers. And then our panels are comprised of multiples of 5. So there's always this patient, stakeholder, scientist composition of each peer review panel. We have 6 criteria within our review against which applications to PCORI are rated. The first 4 will look very familiar to those of you who have done NIH reviews before or applied to the NIH. We have, over time, aligned our criteria to more closely mirror those at the NIH. So those criteria are not terribly unique. The last 2, the patient-centeredness and patient stakeholder engagement criteria, are a bit unique to PCORI. And we talked a little bit about the distinction of the PCORI makes between patient-centeredness and engagement previously. That is reflected in the review criteria. So reviewers are also assessing both whether they think that you've taken into account the interests of patients, clinicians, and other stakeholders in defining what your question and outcomes are, and then also whether you've done the appropriate engagement prior to your application and planned for engagement of patients and other stakeholders throughout your research projects. Does anyone have questions about that? Yes.
I'm interested about how you bring payers into the review process, because in some of my other life, how do you deal with that in relationship to conflict of interest? Because it seems that it would be really hard to include payers without having lots and lots of conflict of interest.
The question is, how do you involve payers without conflict of interest coming up? It's an interesting question, and one, I think it becomes more challenging on targeted panels, because a targeted panel where you're in one, and this is true for other industry individuals as well, pharmaceutical or device, for a targeted topic, more conflicts arise. For our investigator-initiated panels, the topics are so diverse it tends to be easier to find a payer who's not, I mean, we do have individuals who end up being conflicted and they're not assigned to primary and they leave the room for the discussion of the application. But I do think that by nature of there being a pretty wide net of topics covered, we're able to have sufficient reviewers. Else? And just very quickly, the scoring range of 1 to 9, 9 being weaknesses far outweighing the strengths, 1 being outstanding, just to give you a sense of how applications are reviewed. Things move forward to the in-person panel discussion, which is very similar to a study session. Then we get onto this additional review by our selection committee. I just want to highlight it because it is unique, and I can't think of cases where the Board of Governors has not been aligned with the study session panels. It typically, once something gets through review, our board is very pleased. It's just important to engage them in the process, and they do formally approve every slate of studies that is getting funded by PCORI. Sometimes they look at strategic priorities and balance. Typically, they're asking us why we haven't funded enough, how we can get more studies. So usually these board reviews actually open more opportunities for future investments and then also targeted investments. They may say, for example, oh, why aren't we seeing more on this topic that's of great interest? We should really do a funded or targeted funding investment. So I just wanted to highlight some tips for success. These mirror those with the letter of intent. The only thing that's sort of different here is the feasibility of the study piece of this. So the same things apply to your full application as to your letter of intent, the sound rationale, clear decisional dilemma, having the evidence of advocacy for everything clearly defined and showing the evidence gap and how you're going to fill it. All that still applies. But having this piece on feasibility very clearly defined, and especially as a young investigator, showing that you've, if you're submitting as the primary investigator on a PCORI award and you're on the more junior side, showing that you have a strong team behind you will increase your likelihood of success greatly. Just showing that you've got a strong biostatistics person on your team, that you have a clinical mentor, that you've got backup that will be guiding you through the process will increase your likelihood of success. The other thing that we frequently see is because 3 years is relatively short, and this is actually, it's gotten, I think, easier over time as we've refined how the application is actually structured for applicants to demonstrate this. But the more clearly you can demonstrate that you can actually achieve what you're proposing to achieve in a 3-year period, the higher the likelihood of success. So what is the pool of patients that you'll be drawing from? How are you providing a rationale for those you think will be eligible? What you've been able to do in previous studies for the proportion who will enroll, et cetera. And then for an observational study, how are you going to get the data you say you're going to need? And all of those sort of practical, can you do this big thing that you're proposing? Does anyone have questions about that? I think this is actually the end. Oh no, additional funding opportunities after this, but yes. Sure, yeah, we have 21 members of our board. They're actually appointed by the GAO, the Government Accountability Office. They represent every stakeholder group that I highlighted previously at the very beginning. So patients, caregivers, payers, purchasers, industry folks, hospital folks, every clinicians, every group is covered. And there's 4 terms. I can look up exactly they rotate off. Yeah. And there's a formula there, but we can talk offline about that.
Process after you submit the grant one?
Great question. So the question was, is there a resubmission process after you submit once? There is a And very occasionally we will invite someone to resubmit. That doesn't happen that often, but you are invited to resubmit. It's important that you note on your letter of intent that you are resubmitting, and there is a space, albeit a very small space given the constraints of the LOI, for you to respond to how you've modified since your last application. There's also a resubmission letter in the full application to where you can show that you've responded to reviewer comments between the initial submission and the resubmission. But we don't currently have limits on the number of times, etc. That's a great, okay, so the question was, are PCORI awards grants or contracts? And I should have mentioned this previously. PCORI awards are contracts. It does make our mechanism a bit unique, and part of that is in response to our mandate that we truncate the amount of time between research and findings getting into practice. So by virtue of having a contract, there are milestones that are built in. So we will work with you. There's a template as you're applying that you put in where you think you'll be. Oftentimes, that's not quite in the format we would like to see it in. So once you're awarded, we'll work with awardees to sort out what the milestones look like. And, you know, we've heard varying things about the helpfulness or lack thereof of our contract process over the life cycle of PCORI. I think it's getting to the point now where because we've been doing this for a little while, we're getting better at it, and we're building milestones with investigators that are a bit more relevant and aren't quite as onerous as perhaps they were at the beginning of PCORI's trajectory. So hopefully they're actually mutually beneficial. That's our goal, is really to make milestones with awardees that are mutually beneficial and to provide support to get good research done quickly. We're not trying to make life difficult.
The more open between, are there sample and PCORI grants that are out there, or that investigators are obligated to share with new investigators?
So the question was, are there, the NIH has a more open model where there's example proposals to share. It is a very good question. I know at various points in time, we have had, for example, especially in the engagement piece, what does an engagement plan, because there's an engagement plan that's included in each application, what does that look like? I can get back to you. I can give you my card and get back to you on that piece. Yes. The question was, for participating sites, do we prefer that they be geographically widespread? I think it's to your benefit to have geographically widespread sites. Now, I will say there's a different expectation for one of our broad investigator-initiated smaller studies than for our pragmatic clinical studies. Our pragmatic clinical studies, which are $10 to $15 million investments, we expect there to be broad geographic representation across both academic medical centers and community hospitals, all of those sorts of things that you would expect from a large investment. Smaller investments were more lenient. It is, I think, always better if you can show that you're going to have an increased likelihood of generalizability by having diverse sites. But you also have to balance that with the feasibility piece. And so I think it's important that your plan for sites appropriately match the team that you've established and your study question, if that makes sense. Okay, any other questions before this last piece on other opportunities? All right, so I did just want to highlight the investments that PCORI has made in building or investing in communities to be research ready. So in building communities of patients, stakeholders, of clinicians, researchers that can do research. So we have, or can do patient-centered outcomes research. We have this engagement awards program that I mentioned earlier, and we'll talk a little bit more about now, that has explicitly been created to bring these diverse stakeholder groups together and do research projects. We funded in almost every state, made quite a large investment in these programs to date. This highlights the opportunities that we have available to you, and I think this, especially the conference support opportunities and the capacity building opportunities may be of great interest to you. I know it can often be hard to get funds to bring people together, so the conference support mechanism that we have that's up to $50,000 per award and up to 1 year. You can do one event or you can do multiple events within that. Is often very appealing. So this is where you can bring people together to talk about an application that you'd like to do. It's something that we've heard a lot of people really like that we have that available. And then we also have our capacity building awards, which are up to 2 years and $250,000 to bring the community together to really become PCOR ready together. And so that may be another thing you're interested in thinking about. If you've got a group of people who want to do this work in the future, either apply to PCORI or apply to another funder, this can give you a little bit of funds to get started and to do that prep to research work. Does anyone have questions about that? Yes.
This is only for things that have previously been funded by PCORI.
That's actually, yes, so that is the case, and there are other dissemination and implementation funding opportunities that are becoming available, and I would encourage you to take a look at the upcoming funding announcements. So we're trying to think more and think creatively with our colleagues at HRQ about what the needs of the community are and how we can respond. And so most of what we funded is pushing out, or most of what we've started on now is pushing out PCORI funded work, but I would encourage you to keep an eye on future opportunities.
Nicely fill in a gap for other funding. So people don't have to jump from one trial to another without ever training clinicians or teaching families or sharing information.
Yeah, so the comment was it's a nice place where we can add value and sort of maximize the return on investment. We've heard that a great deal. We're really excited about the potential, both for what we funded and what's been funded elsewhere, and then also to draw together what we've funded. I mean, we know that research doesn't occur in a vacuum. One study isn't going to, by itself, necessarily change practice. So bringing together the community and bringing together various researchers who may have sorts of added interest in results and thinking creatively about how we can really push findings out. If you have ideas, I can connect you with my dissemination and implementation colleagues. Okay. And actually, I had this idea. Yeah, this is a big part of our mandate. It's sort of, we spent the first 6 years of PCORI getting set up to do the CER piece, and now we're really thinking about this and thinking about infill investments and how we can be really targeted and thoughtful about how we can do some things that create a big impact and not necessarily for a great deal. That was the end. Are there other questions that people have? Yeah.
So in terms of projects,
Yeah, so we're looking for innovative ways to disseminate and implement. So yes, exactly. Testing methodologies that have been developed, trying to think about creative ways that will get findings into practice more quickly and will make a bigger difference than perhaps some of the more routine ways. So, and that's something where this work, as I mentioned, is pretty early on. So I would encourage you to take a look at our website, see what we funded, and to look at the funding announcements and to see what's coming, because I think there's going to be more in that space in the coming months. Yes. Yes. That is an excellent. We're proud of the reach that we've gotten because I think we do better than the average. It's hard. I mean, when you have peer review panels who are looking at teams and environment, and that's why I said too, the more you can show relationships with other sites and infrastructure that will help to support your study, the better. I think that there is a need to try to create a bigger investment in sort of underfunded areas geographically.
One of the things you always the ability of if there's things very expensive.
So the question is something that's a very new, very expensive intervention less likely to come through a funder like PCORI? I think that's a big tension to be, and a philosophical tension in sort of the world of CER is what is CER and like what's the best place to be making investments? Is it large drug studies that are looking at new interventions? Is it answering age-old questions and clinical dilemmas that plague our system that perhaps aren't addressing those expensive innovations? I think that the challenge, one of the things, because this work is supposed to be real world, it is supposed to be, the mandate that we have is that coverage be provided for clinical care by a patient's insurance plan, typically. And so intervention costs are not typically covered by PCORI. And when you get to a case of comparing a very expensive thing to a less expensive thing, often it isn't something that's currently being covered by payers. So unless you can get the payer or the manufacturer to donate, it gets tough to do CER in that context. We do have examples like for hepatitis C, we did a targeted funding announcement. And that's a case where we are looking at high cost drugs, but the payment issues do make it very challenging in those kinds of situations.
Thank you